Good morning. My name is Mike Margolis. I'm past president of the IABDM, and I really want to welcome you here to our second introductory course that we have started at the IABDM. I would first like to acknowledge our sister organization, which I'm also a member of over 20 years. Farah and Kim are here from the IAOMT. They're assisting us on getting this recorded, and hopefully we'll have a long-standing tradition of the two organizations working together. Next year, we are going to have a joint convention at Reno, Nevada. What are the dates? September 10th, 11th, 12th, 2016. All three alternative dental organizations are going to be working together at a convention. Dr. Fisher and I are setting up the speaker program, and it looks very, very exciting. So block that date out and get your reservations in early. As I found out, my reservation here didn't go through, and I'm staying in another hotel. So anyway, my talk this morning is on daily record keeping, the practical and legal ramifications. Keeping the record straight. In dental school, we were taught to take health histories, do an oral exam, record existing conditions, take x-rays, make an evaluation, develop a treatment plan, and inform the patient what they needed. We never really had the approach of differential diagnosis, because when you take an x-ray, you see a gray spot, it's a cavity. Not very exciting until you got into oral pathology. Legally, or traditionally, dentists keep very poor records. Do not record what they find correctly. They also don't put down all the procedures and the diagnosis that we do. Lack of proper patient consent, daily records with patient interactions, and consent are lacking. Telephone conversations, insurance connections, even after our telephone conversations, are very rarely recorded in your chart. Legally, if something is not written in a patient's record, it never occurred. Basic steps of record keeping are as follows, and we're going to go through every one of these, so I'm not going to read them here because we will do everyone individually. So let's take a look at the other important aspects. Telephone contact, front desk. How many of your front desk people write down that you had contact on a daily basis with a patient? Rarely done. After hours emergencies, those are the tough ones to record. Appointments scheduled and canceled. Staff communication, notes in the office. How many times does your staff actually make an entry in the chart for you? Hygienists. We have a few of you here today. Very, very important. You'll see this later. Insurance company contacts and benefits. I actually, first in 30 years, had a complaint from the Attorney General office in the state of Arizona that a patient came to my office. This was just a week ago, Friday or Thursday, and she paid for her initial exam, and her insurance company, can you believe it, did not pay her back? So she says we committed fraud. I'll show you a statement that she signed showing that that's a little ridiculous, but the fact of the matter is that it happened. We want to know consultations with other doctors, medical doctors. I do a lot of surgeries. I am now asking for records from other doctors and dentists, so I have a history of what this patient's gone through. Pharmacies, scripts, written refills, up-to-date medical history. Every visit, the patient signs a paper stating if there's a change in their history. Letters and referral information is clearly noted. So you're going to have a pattern. We start here, the initial visit. You're going to meet the front desk first. You enter the patient information in the computer, responsible party, possible family issues, divorce issues, big, big thing. You got to have a daily sign-in sheet, especially in divorced families, because that actually, I got called to court for that. Insurance, yes or no, and benefits, health information and alerts, other x-rays, pictures. Then you got to pass them off to go to the back office, where you should, on an initial visit, do full mouth series, x-rays, and pano. What happens if the patient comes in and says, "Doc, don't worry about it. I don't like x-rays. I don't want them." What do? Go ahead. Bye-bye. I can't help you. I did that. Oh, I won't tell that one on stage. We'll talk about it later. You review the health history before you touch them. What happens if you go in and you start probing and you turn around and say, "Oh, you needed to be pre-medicated. You just had a new joint replacement." You have to know that before you get started. Complete oral exam, charting, periodontal probing, case type. Now, most of the time this is done by my hygienist. You need to put the case type. Are they case 1 or case 4? Soft tissue exam for cleanings, finding missing teeth restorations, decay or broken down restorations, abscesses, other clinical findings, patient consultation, referrals. Last week, again, true stories. Patient comes in, he's out to here. His whole left side of the face is caved in. When he was 4 years old, he had an aggressive cancer. They did surgery, radiation, and half his face is caved in. Nicest person you'll ever want to meet. Comes in, says, "Well, I saw this other dentist, and he gave me some penicillin because he said I had an abscess from the angle of the mandible to the canine, 22 millimeters out, hard as a rock." And he was given penicillin. Got on the phone, called an oral surgeon, had him in that office within 2 hours. He's set up for surgery. He may not survive. I don't want to be that first dentist who gave him penicillin and said he had an abscess. But my records are very implicit of what my impression was. I gave 3 differential diagnoses, sent it to the oral surgeon, and he didn't carry that insurance, so he got him into another office. So we're waiting for that report. It's not going to be a pleasant one. So, let's see, did I go the wrong way? Here we go. Then you have to have a course of action. You can present the treatment plan then or the next appointment, periodontal care, set appointments, recall schedule, restorative, crown and bridge, orthodontics, surgery, any other things that you need. Always record your referrals. If you have a referral sheet that you make a copy of that and put it in your chart that it's been done. Now, if you have a restorative, the person's already been there, been in your office. But what do you have to do? You have to enter the information into the computer, responsibility of the parties, make sure it's up to date, change the medical history. I should have coming up here what we do for that. It's a little sticker that patient signs and dates every visit they come in. Back office is taken there, place a sticker in the chart. Assistants, hygienists, what are we doing today, and record their answer. How many times do you think the patient's correct? They made the appointment, right? How many times do you think the patient knows why they're there? We're running 60%. 40% of the time, they don't even know why they're there. I have an appointment. Something's wrong. Then, repeat and explain the treatment for the day. Take a blood pressure. Before you inject, you inspect. You don't want their blood pressure 200 over 120. I wouldn't want to inject them. And then what are we going to inject them with? And then oral cancer screening. Why do I say oral cancer screening? Because too many people come in, and one of the attorneys in my area sat there and said, "Mike, I was defending this dentist, and the patient died during the surgery." The family was awarded $1.8 million, of which he had $1 million covered by his insurance company. Who makes up the $800,000? Then you take your oral cancer screening, and whatever you need to do in the course of action, anesthetic, material used, continually going. Crown and bridge, everything's basically the same thing. Prepare the patient, Make sure you do an oral cancer screen. How long does that take? How long does an oral cancer screening take? How long? Oh, that's way too long. No, well, if you want to use the Valscope, it will take 3 minutes. You're right. Okay. You had a question. You know, basically, that's an excellent question. I don't like going over 90 on the bottom, the top. And I had a patient in the other day, we were doing an implant on her, and the second she walks in the door, 200 over 120. Just because she saw me. Yeah, I have that effect on some people. But the whole thing is, you can vary that, because when she was at home that morning, she was 120 over 70. So, but if you're over 150, 160, and you're over 90, 95, you got to get them calm. So then we use homeopathy. We'll use rescue remedy, and then there are a few pressure points, the Hoku point, and a few others that you may use that you can get the blood pressure down instantly. Also, nitrous oxide. Nitric oxide is wonderful in getting people calm. And with those people, I love a Xanax or a Valium. In fact, I would like to take one, but I don't think that's allowed. So we go from there. As you can see, once you get your staff doing this, it's routine. It's just basically routine. So Crown and Bridge second visit, same thing. You got to take a blood pressure. You still have to put the sticker in there, and you want to do an oral cancer screening. Few people, an oral cancer screening, you don't have to be too fancy. You want to check the back of the throat and the side of the tongue. It does very, very well. Then dentures and complete removable partials, basically the same stuff, whatever you need, it's right there. It's so simple. Get to a routine. Get to what's going to be good for you in your office, especially when you have these multiple step treatment processes. Great communication. How many of you send a denture in without the patient signing the chart saying, I like the way this looks? Do you have them sign the chart and say, I accept this to go process? Because if you don't, you're going to be making them a free set of dentures every single time. But you like them. Well, I didn't know. And you know they don't fit that well because they haven't been processed. So you want the patient to sign your record. If you're going to do anything special for them, or if you're going to change a price or whatever, write it in the chart, have them sign it. Remember, this is a legal document, and we're going to get into consultation forms later, or consent forms. Surgical implants, and you see, I didn't put our surgical setup for everybody, but my surgery treatment plans are 20 pages. 20 pages long, and they initial the bottom of every page, and they sign a few and date every one. So what you have, again, sign in any change in health history, and then we place a sticker in, x-rays, and ask any concerns, what are you doing here today, and take a blood pressure. Another thing that's important when you're doing surgical patients is know your state laws. If you have an individual who is under oral sedation, some states require that an assistant must stay with that patient from the time they get the medicine until the time they leave. And they're saying that you cannot even clean up the room and carry the instruments out without leaving another assistant in the room. That's how the laws read. So you have to be very, very careful. Now, a number of people in the organization do IV sedation. Same rule applies. You're not supposed to leave them alone in the room. You're supposed to have somebody in there at all times until they go out the door. Keep your records straight. So here we go. We're going to go through all these fun things: front desk, patient information, health, medical update, sign-in sheet, schedule. Why do we reschedule appointments right away? I heard a laugh. Hi, Martha. Basically, what's your lifeline? How many hygienists are here? Raise your hand. There's the lifeline of your practice right there. Treat them well, pay them well, respect them as professionals because they are professionals. They're the ones that got your 6. They're the ones, I'll tell you, my hygienists, I love them. They will find more cavities than I will ever find because when you clean, you're going to find something wrong somewhere. And we have a rule in the office. I don't care if we put that crown in or somebody else. If they find something wrong with the crown, they write on a separate piece of paper what they find. I go over it and check it. Simple as that. Then collecting money. Sign-in sheet. Date, name, responsible party, adult, for minor, time signed in, any changes in history, bingo, medical. Management tool. Are we getting our patients back in time? So some guys are so sophisticated that they sign in on a computer, they have the check-in time. They even have the time that they sat them down, had a bathroom break, all in their own records, because that's the way their system's set up. No-shows. Do you charge for those? We do. And then legal complications, divorce, custodies. This doesn't work anymore. We used to have a sign-in sheet. We had a cute little tooth and say hi, and everything's there. What's wrong with it? HIPAA violation. You can't do that. But over here, the sheets come out, and a blank sheet is over this, and then when you take the peel or take the thing and put it in your daily records, this has the signatures and times and everything underneath it. But that would be a blank page. Carbon copy is saved at the end of the day. And this is the guy. I have no connection to anything. I'm not selling anything to anybody today. Okay, I keep on referring to this. This is the simplest thing in the world to do. You can use an address form, and you can have this, and we ask, any change in health history, date, yes, no, print, sign. That goes in the record. Now, you can have a complicated sheet that's laminated. Please read this before you sign that and have that at the front desk. When I had my knee replaced last year, I signed so many forms that this guy wasn't responsible for anything. If I died on the table, that's my fault. I shouldn't have died. But the whole thing was, we as dentists should start looking at some of these things. My consultant had, and so did I, kidney problems last year, kidney stones. I had to sign the same thing. And if there was a complication, then we agreed to arbitration instead of court. In court cases now today, if you get a numb tongue or a numb lip, people are collecting anywhere from $300,000 to $1 million for these things. And yet you still sign. There's a possibility you could have this, this, and this. They don't care. Sue crazy in the United States. If the answer is yes, then the patient is seated. The assistant will ask the patient, why did this change, and write it neatly in the chart and point it out to me before we get started so I can make any comments or know what's going on, and then we can continue. Then over here, here's your basic information. Now, the name of my practice, guess what? My dentist. I was out drinking with somebody a long, long time ago, and that's how it came out. I said, well, my dentist says, and my dentist says, well, guess what? I'm my dentist. So, the state of Arizona, you can't take it away from me. We thank people for selecting whatever name you want to help us meet your health care needs. I didn't say dental needs. Health care needs. Please fill out the form completely in ink, and you have questions or need assistance, please ask. Identify yourself, logo, and welcome. Thank people for choosing you. It's really important that they thank you. Then you got to do your basic information. Yes, unless they're paying cash, you need a Social Security number for everything else. And then very basic address, student, business, spouse, who may we thank for referring you. You know, in our computer, after a patient refers so many people, we send them flowers, we send them something, tickets to a movie or whatever. What's it cost you? Just a simple thank you. And then in case of emergency, you need somebody to contact. Over here, responsible party. In God we trust, all others pay cash, but we also have services provided by an Arizona licensed general dentist. This is a state law in Arizona. If you advertise and you don't put that in there, you've broken the law. It's a misdemeanor. Okay, but it's ridiculous. You have to do it. So responsible party, and then that statement. Check your state laws or providences. And then over here, insurance information. We have a primary, secondary insurance. Most dental offices lose patients due to insurance changes. Second to patients moving away. Always record conversation with insurance company, telephone number, extension, person's name, etc. So what we do, we have a form here, and the girls write the number that they talked, number and person they talked to, waiting time basics, the date, patient's name, social security number, employer, effective date, calendar year, what their maximums are in, well, we don't do endo, but we have perio, etc. We have deductibles met, coverage, so it's all there. And then on the back, we just have a sheet of paper with lines on it so they can keep notes with the insurance company. That doesn't absolve them from putting it into the daily record, but that way we know what phone number and extension they talk to. Now, I'm thinking, here's this woman who filed the complaint with the Attorney General's office, and she signed this. There's a thing on my sheet that you sign. It says, to avoid misunderstanding regarding dental insurance, we wish the persons responsible to know that all professional fees rendered are charged directly to them and that they are responsible for payment of fees. We will prepare the necessary forms or reports to help the person responsible obtain benefits from insurance companies. There's a number of offices in my city that won't do that anymore. They say, here's your receipt, you contact your insurance company. Upon receipt of full or partial payment of bill, we do not render our services on the basis that insurance companies will pay all our fees. Each fee is individual for the individual patient. And yet, she filed a complaint that her insurance wasn't paid, didn't pay what they were supposed to. Then you get their medical. Are you under medical care? If they are, it's not a bad idea to get the name of the physician and find out why they've been hospitalized. Are you taking any medications? This brings up a whole bunch of things. I do a lot of surgeries, and my patients are on a lot of different medications, anywhere from an aspirin to Bellaluca, nanokinase, which thins out the blood, vitamin E thins out the blood. If you take vitamin C and you're going to do surgery or you're going to do anything that needs an injection, you need to inform the patient that oral vitamin C, not IV vitamin C, may break down the anesthetic. And that anesthetic might not last very long, and it makes a very unpleasant situation. So you have to explain and know what the interactions are. Record any information concerning medical treatment the patient is receiving. What do you do if you need to pull a tooth and a person's on bisphosphonates? You don't. Don't we refer to oral surgeons? Okay. The other thing is you can do a CTX score. CTX tells you what the turnover rate of the bone is from osteoblast to osteoclast. If you're under 100, you don't touch that patient for anything. Send them to a prosthodontist. You don't want to play with this. If you're under 150, you don't touch them. When you get over 400, it's not a problem. This is my benchmark. They say over 200. I wait till they're over 400 before I'll even touch them. But a CTX score is accepted in the medical dental communities. My son's an oral surgeon. He just doesn't want to touch them because he knows the complications that can take place. He had an interesting story on that. One of his instructors in oral surgery was one of the first people to discover that bisphosphonates really had an adverse effect on dentistry. He extracted tooth number 3 and took out the ramus of the mandible. It broke right in front, about the area of 30, and he still had the nerve in the bone. And after they cleaned up his pants and they tried putting the bone back together with screws and plates, that stuff doesn't heal. The woman literally lost her jaw because they couldn't reconstruct it. So, bisphosphonates, suck of the devil, can prevent a patient from bone healing. If you have to extract a tooth, consider referring to an oral surgeon or, in this case, an endodontist. Some patients do not know their drug is bisphosphonate drugs. So you have to know. So patient medical, sex. If female answers, are you taking birth control pills? Are you pregnant or nursing? What do you need to know about birth control pills? If a woman's taking oral contraceptives, antibiotics may disable the pill. You may become Uncle Dr. Mike. Okay? So you have to discuss these things with people, okay? Bisphosphonates. Here's the latest up-to-date. Zameta is the new one that I'm seeing a lot of, but Actonel, Ardea, Bonivia, Derodrin, Fosamax, Fosamax Plus, oh boy, Reclass, and Skilled. So this is important to know. Jaw osteonecrosis seems to be associated with trauma. Most cases occur after extractions or are located near the myeloid ridge, third molars. Of those not associated with extractions, they are commonly associated with dentures or exostosis. We call them tori. Bless you. And the risk. So osteonecrosis will appear as exposed yellow-white bone. Sinus tracts and painful ulcerations may also be present. They're basically referring to medically induced or medicine-induced osteonecrosis, your bisphosphonate drugs. So we go through and we do the basic. You can get any health form. You'll find high blood pressure, pacemaker, all the way down through fibromyalgia, heart surgery, heart attack, anginas, and then rheumatic fever, tuberculosis. All this is in the notes, and you should be, if you signed up, this lecture should be included in your USB information. I share this freely with everybody, and if you do it someplace else, all I ask is that you say, hey, thank you, Dr. Mike. Then you have epilepsy, venereal disease, blood transfer, jaundice, drug abuse, etc. Then, can the mystery behind your disease be coming from conditions in your mouth? As a biological dentist, any one of these conditions or combination of these problems can lead me to believe that this patient may be allergic to materials in their mouth, have multiple root canals, or poorly performed past extractions. Other situations may be connected to sleep apnea, chronic fatigue, fibromyalgia, cancer, and many degenerative or unexplained diseases. So we go through and we're asking the basics here. Do your gums bleed? Are they sensitive, sour, sweet? Reaction? Do you have pain in your teeth? And then do you have clicking, pain of your jaws? Do you have frequent headaches? Do you clench? All basic things. Do you wear a denture? Have you ever received oral hygiene instructions? You know how many times we see no on that? I haven't met a hygienist that doesn't love telling everybody how to floss their teeth or something. So, this has to be clearly stated. Payment for services is due at the time the service is rendered. Imagine going into a grocery store and say, hey, my insurance will pay you in 6 weeks. Come on, think about it. You go into a grocery store, you got to pay. And that's what I tell my patients. Well, can I have 3 weeks to pay this? I said, in God we trust, all others pay cash. In the event the payment is not made, when the services are rendered, a monthly statement is sent. Payment will be expected with 10 days. Is received. All appliances, dentures, crowns must be paid for the time they are delivered or in compliance with special payment arrangements. Amazing how many people come in and want to make an arrangement after it's in their mouth. And then with all accounts, payment is not received in 10 days, statement is received. Finance charge, 1.5% is what was legal at the time. In an event that it becomes necessary to place account for collections, underside agrees to pay in addition amounts due and owing reasonable cost. Becomes necessary to file legal action, another side agrees in addition to any amounts due and only reasonable attorney fees and court costs. By signing below, you indicate that you have read all the foregoing and understand the same. Your front desk people need to do a heck of a job to make sure they understand this. And then guess what? We actually asked them to sign that. Now, I understand there will be a fee of $25 per half hour. We're thinking of changing that to make it a lot higher. That was written 25 years ago. How much does it cost you when a patient doesn't show up? Is amazing. So, this is what I call the basic patient record entries. Patients sign in at the front desk, update their personal medical. They sign that little sticker, print and sign. Router. A router is a thing that we use in the office that has all the codes that we're going to use for the day and what the appointment is. Patient is greeted and seated. This is called the pass-off. So you go to the routine checkup, emergency treatment plan, etc., but all starts with x-rays. Consultation, that's the only time we're not taking a blood pressure. Probably should be after you get done with giving them the price, but pardon me. And then you have active treatment. So the 5 transitional steps. 1, medical dental history update. If yes, the assistant asks and records a medical update. Any new instructions, RXs from your physician, ask the patient, why are you here today? Record their answer. Is there anything bothering you, or do you have a concern you want the doctor to look at? Record the answer. No other concerns. We can write that in. Doctors and hygienists, what drives you crazier? You get done, you're degloving, you're setting the patient up. Joan, what can you look at this? I got so ticked with the patient the other day. I looked at her, I said, you know, every single time you've done this to me, you're driving me crazy. The answer is no, I can't look at it today. I already took my gloves off. I've already taken my mask off. The assistant asked you, right here, she wrote down, nothing, no other concerns today. Next time, you'll remember to tell us. And I got up and walked out. She came up later before she left. She gave me a hug, a kiss on my cheek, and said, I'm sorry, you're right. I won't ever do that again. And she hasn't. So, do it gracefully. Do it gracefully. Is there anything bothering you? Okay, and of course, this is going to save you in a lawsuit. Oral cancer screen, OCS. Results are recorded. Last year we found 4. This year I'm up to 3. So it is there. And one of the most unique ones was the uvula looked like an orange peel. Think about that. They're nice and shiny, and this thing. So he said, well, I burned myself on a pizza last week. I said, okay, we'll see you in 2 weeks. It will be healed. If it still looks like that, I'm calling the doctor. Came back in 2 weeks, still looked like an orange peel. Sent him over there, leukemia. We weren't taught that in school. Use your sense. Make sure you're there. All paperwork's filled out, entered into the computer, check benefits, etc. All medical alerts are put in, router charted, HIPAA compliance signed, consent for use, disclosure of health information. Meanwhile, patients taken back for radiographs. All medical alerts are noted for the back office. We have that on our routers. Did I miss something? Yeah. Okay, so how many of you take complete series of x-rays? Okay, you have to. Unless they bring in a readable set of x-rays, and I had a patient come in, if we have to redo x-rays, I don't charge them for it, I don't care. I'm not going to make a living off x-rays. Some people, it's a big deal. But with digital x-rays, who cares? The other thing is, it's not too hard to show a patient what a real series of x-rays really looks like when you get some professionally done ones, and you just hold them up. Which one would you like me to diagnose off of? Communication, hands-on, be there. Don't be afraid to touch a patient in a nice way on the shoulder or hands. But keep it above, except for the shoulder, keep it above the neck if you can. Okay, then photographs. We start with a face. We pull the cheeks out. We got a smile. We take the side, up, and down on every adult that comes in. Because a lot of these things later on I'm going to be restoring. Now I got their beginning pictures. At the end, I can take the same series and you can see a big difference from, hopefully, from the beginning to the end. So it's just smart to have. Then, oral examinations performed by hygienists and or dentists, in our case usually both, record all missing teeth, decayed, restored, type of restorations, implants, any type of implant too, any dentures or removable partials are worn, any observable cysts, abscess, soft tissues, abnormality. Prior to starting work on a patient's mouth, start something else. Have them rinse with anything, including water actually, but a mouthwash, that removes 90% of the bacteria in their mouths. So it's safer for you. Then, oral exam, again, hygienist, you're better at this than I am. Give it a case type. Put it in the record. Appropriate periodontal charting with a treatment plan consent form for signing. Do you use lasers? We're using one of these inexpensive lasers after cleanings just to get rid of the bad bacteria. We have patients that ask for it. It's an extra $50 charge. But the patient says, you know, it felt so good. Can we do it again? And the answer is, yeah, I'll take your money. And I'll provide a good service, though. Oral examination performed, oral cancer screening is noted and recorded. I'm sorry? I don't remember the name of the laser. There's so many out there. BioLaser's got one for that. Anybody else have one that you'd like to mention? Because, like I said, I'm not endorsing any. But if you look and just look up perio lasers, you don't have to get a perio millennium, which is, what, $80,000, and you go through their training, and you get some of the best wine that you'll ever have. Yes? Okay. Yeah, they go for $2,500 to $3,500. They're very inexpensive. They're a little unit that you put up there, and they'll talk to you. Ours talks to us. You just turn it on. And what do you have a brand name? Picasso's? By Dent Supply. Okay. Odyssey is another. So they're out there, and they're inexpensive, and boy, I'll tell you, the patients love them. And they do a nice job, because if you use those and you got like a 4 or 5 pocket, if you bring them back every 3 weeks, every month, those pockets generally will go down as low as they're going to go without surgery, and usually you don't need surgery. Okay, consultation, discuss findings. More information must be given to your patient because they may not understand full scope of practicing biological dentistry. Explain or review blood antigen testing. Would you suggest the removal of all metals or not? As a biological dentist, you may need to explain what you do differently than traditional dentists. I am different. Now, we've even updated our disclosure a little more, but I do this on every surgical patient. Disclaimer. The Arizona State Board of Dental Examiners, other state boards, the American Dental Association, I think Dr. Kennedy said it better, the American Dollar Association, the American Association of Endodontists, the American Association of Oral Maxillofacial Surgeons, the American Academy of Periodontology, North American Dental Schools do not agree that past extraction sites, root canal teeth, or ADA-approved restorative dental materials, dental amalgam, mercury fillings, can be harmful to a patient's health. Dr. Margolis believes they are. Dr. Margolis makes no claim, and you have to put that in there. Can you turn that back down? Thank you. Oh, is that okay for everybody? Oh, okay, she needs a little more up. Just tell us where. Okay, a little more up here. I'm sorry. Dr. Margolis makes no claims by treating, okay, any of these conditions will improve a patient's overall health. You have to put that someplace in your consent form, because so many guys go out there, and remember, what you say is not what your patient heard. Can everybody repeat that to yourselves? What you say is not what that patient heard. So, by signing below, I acknowledge that I have been made aware of this disclaimer, and you have that there. Initial office visit, clinical findings, discuss presentation, perio care, restorative care, which teeth need restorations, and why. Everybody's asking for a diagnosis. Well, broken tooth. Patient reactive to metals. Patient wants a pretty smile. Do you put down patient wants mercury fillings out because they're sick from mercury fillings? What you put down, I had a patient actually write that out. I said, can you cross that out and put down you want pretty teeth? The state board will accept pretty teeth, but they won't say, you know, you convince them by doing that. And you can't make a promise, because depending on the genetics of the individual, if they're APOE 2, 3, or 4, which Dr. Boyd Haley has pointed out numerous times during lectures, that genetically some people can detox and others cannot. It doesn't matter what we do. It matters in how they're treated and how they detoxify. And what is needed, differential diagnosis sometimes is there. And then you can have orthodontics, splint therapy, a whole bunch of other things for a whole bunch of stuff, front office, back office, flow of appointments, putting together daily record and keeping. So if your front office doesn't support the back office, and you hear from the back, hey, you idiot, you didn't give us the x-rays. How professional is that? You have to, oh, we can't find the damn chart. Don't say chart. But you should have everything organized so it can be found. And then going by the steps, sign in, pull charts, sign strip, attach to the router, sign, there's been no change in medical history. Why am I repeating this? Because it's important. The 5 discovery facts are recorded and 3 questions are asked and recorded. Date of treatment, have to put that in there. And the reason I'm doing this is I am amazed at the records that we get brought in, because so many patients send their records to us. We had one record, this is the best. There was a date, 15 MO, and the doctor signed it. That's all they had. So, oh, don't worry. With another hygienist, it was cleaning. No probing, did a cleaning. Again, sticker and re-ask question. Ask the patient, why are you here? Record their answer. We have scheduled to do X, Y, Z. Is there anything bothering you, or do you have a concern you want the doctor to look at? No other concerns today. Record a blood pressure, oral cancer screening. Record that you did that. Then you attach this for the perio. Same basic thing. What are you here for? Why are you here? Is there anything bothering you? Blood pressure. And then over here, this is what it looks like. Periodontal chart for Mr. Smith. Routine 3 or 6 month appointment, September. Mr. Smith says he is here for his routine cleaning. He's concerned about losing a filling in his lower left tooth. It doesn't hurt. He's a type 3. Patient present for a routine prophy exam. Well, type 3 is a little more than routine. Moderate calculus, clean it up, go from there. Pocketing, increase in the posteriors, because we have that in the chart. Need SRP over there. Negative. 19 has decay and a broken film, will need a full crown or zirconium crown. Checked allergies with, now I use a Clifford test. There's biocompatible tests, which Dr. Gruby's group will do. Clifford does the Clifford test. Treatment plan presented, signed, patient scheduled, and hygienist name, my name. So that's basically what you have to have something in there. And like I said, if you're taking pictures, you can, but this is all on a USB stick, so it's going to be made available for you. And then we have the treatment plan, fees, etc. They'll sign that before we do anything. The treatment plan gives a description, related expenses. They have no insurance, so in God we trust, others pay cash. Patient does not have insurance. Okay, so he signs, and then we have another consent form. These consent forms tell them that you might have a problem. You might need some crown lengthening. You may need some other stuff going on. I understand commonly reported reactions to local anesthetic. How many people use epinephrine in their anesthetic? One? Okay. I used to. I found that every 4 or 5 crowns I prepared and I used epinephrine, I had to do a root canal on every 1 out of 4 or 5 root canals. I went to a lecture somewhere and a guy says, why do you use epinephrine? First, the patient doesn't like to be numb that long. 2, how long does it take you to do a crown? The average in the room was 1 hour and 15 minutes. So, sat there, how long does it last without epinephrine? About 2 hours. So why do you need it longer? What does epinephrine do? It stops the flow of blood. And what does the tooth need most when it's being traumatized? Blood, oxygen, nutrition, and get rid of the waste. So what I was finding was that one tooth died between 18 to 24 months later. Why? Because it took a while for all this garbage to build up and the tooth would die. So it was beneficial to try it. Then it was always 1 out of 100 needed a root canal, and that was the one I told them that they needed. That was long ago when I used to do root canals. In 20 years, I've done 3 root canals. 2 of them on people who went into hospice. So it would have been more of a trauma to them to pull it than it was to just get them out of pain. The 3rd one was for orthodontic reasons, and that tooth is scheduled to be extracted when ortho's out and a zirconium oxide put in. Any questions? Yes? John? Okay, you can get Marcaine or some other anesthetics that have no preservatives and no epinephrine. So you can order that at a compound pharmacy if you like. So patient must stay on, okay, so we have everything on here. We give a guarantee on some stuff. It says a patient must stay on his or her continuing care maintenance program with our office. Continuing care involves a doctor exam in conjunction with your routine cleaning. Crown and bridge will be covered for the first 3 years after placement with the exception of abnormal wear. Doctor will determine if lab costs will be charged. I had a guy come in 5.5 years later. The crown was beautiful, but he had decay underneath it. He has good insurance. He's been to every cleaning, and he's a school teacher. Every year I give their department money for them to go out and buy shirts that we have our name and other people on it, and they make money and it goes back into the thing. He's never missed a cleaning in 10 years. I looked at him, I said, you're such a good patient, we're just going to take whatever the insurance pays. If they pay nothing, I'm not worried about it, we'll take nothing for it. What is goodwill worth to you today? He has sent me 25 new families, not patients, families. Take a look at some of the things. You don't have to make $1 on everything you do. So again, we do this. This guy's on high blood pressure, Azor. Do not use epinephrine anesthetic. Patient has no concerns. Patient signed treatment plan, consent form, and basic entry. He knows we're going to fix, she wrote in fix, instead of with, which was fractured. A state board, if they read this, they know why we're doing 19. They can go look at the x-ray, because we have an x-ray. Picture taken. Okay, we took a picture also of the mouth of the broken tooth. Blood pressure, pulse. Here we put the amount, cc's or 2 carpals. use of rubber dam, separate oxygen removal protocol utilized, and we're going to have Dr. Marion do that later today. Prepared number 19 for porcelain crown, Pentamix, impression, temporary, ultra cement, adjust by patient tolerated procedure well. Next visit, seat crown. Basic, normal entry. And then over here, when you use nitrous oxide in the state of Arizona, you have to record when you start, the rate of flow, percentages, and when finished. Oral sedation requirements vary between states, so you need to look at the laws. I would go online. I would print those sections out, because none of us are going to go back and look at the dental acts in your state. They are the most boring things in the world. But know exactly what they say, because they are going to hang you if they can. And then over here you have a consent form again. And then we have Anita Martini. She drinks a lot. We have a treatment plan composite. Simple thing, not much, but it tells us we're going to use oxygen, a mask over here. Now, starting 2016, we're going to have another one in there, and that is mercury protocol. We're going to have a charge for the setup of the room, use the mercury cream, etc. And Dr. Seward will be showing us that later today. So the reason you take this and blow it up is so people can read it. And then we go through here. Surgical treatment review. After initial appointments, referral from a physician with their concern, patient health history, written health history or patient's concern, full mouth series, pano, complete oral exam, including periodontal case classification. I happen to have a Cavitat, which is an ultrasonic imaging machine. There's also EAV. Any other relative testing, a treatment plan is put together for detailed treatment plan consultation. Then you have, due to the nature and controversy of extracting root canal teeth and treating avascular necrosis, I have quit using the term in the office NICO, because state boards go nuts on them. But they all love avascular necrosis. I scheduled an appointment with my office manager, coordinator to take notes. When we do this, I have a person recording everything, writing it out. We're thinking very seriously of getting a camera in there and recording these consultations. Because then there's no question that we went through everything, we talked about everything. It also makes me a little more professional talking to the patient, because I like to kid around a lot. I only discuss the treatment plan. The office manager is present during the entire thing. Why? Because she talks about the money. Patient asks me how much. I said, you'll talk to the office manager about that. I describe avascular necrosis as part of a differential diagnostic term, because cavitation in NICO is not recognized by the ADA and insurance companies, whereas avascular necrosis is recognized and accepted CPT diagnosis. Insurance, dental, medical condition, especially medical condition. I have a son that's an orthopedic surgeon. He considers it malpractice to leave ischemic osteonecrotic bone in the patient. And that's what the literature is saying. And then, do not promise insurance will pay anything. I give you a lot of personal stories on all this stuff. The one thing I'd like to say is, in the very near future, there's going to be a design IRB with some universities across the United States that another person and myself are designing. If people want to get included in this, please come talk to me. There'll be very, very strict protocols for everybody to be on it, because we're going to go ahead and we're going to scientifically produce, we hope, at least 50 peer-reviewed articles to go into major magazines, because we're tired of people saying it doesn't exist. It does exist. And it's going to take both organizations, the IABDM and the IOMT, to make this happen. And we're not going to ask for any funding. You should like that. We might, the individual doctors won't, some of the other professionals who aren't dentists might need something. Yes? Okay. Okay, the question is, there's a code on the sloughing of the bone. That was designed for medically induced or bisphosphonate-induced Nico lesions, because the tissue falls off and the bone comes up, it's yellow, gray, and icky. If I see that walk into my office, I don't touch it. I send it to an oral surgeon, because these people need to be hospitalized. So if you use that term and you do not have hospital privileges, you're going to get ripped. So I'd be very, very careful with that. You'd have to look on the forms. I use alveoloplasties because you got to reshape the bone when you're done. That's the code that I've been using, but they're limited, and that's one of the reasons we want to do this study, because we want to get codes that are going to be better for this type of thing. But it does show. I also was using DNA biopsies, and the state board does not like DNA biopsies because they don't understand. One of the investigators said, well, when you culture things, it's not a biopsy. He didn't understand what a DNA biopsy is. Whoops, I don't know what happened. He didn't understand what a DNA biopsy was. Had no idea that it's a fingerprint, it's a footprint. It's just like any other thing. It just doesn't give you the condition of the bone. It gives you what gave that condition or what created that condition. So there's differences in philosophies. So over here, this is the front page of our treatment plan. Office copy, there's a patient copy. My name, my cell phone number. I'm the easiest doctor in the world to find. I give them my personal emails. Now over here we have NICO. We put AVN or avascular necrosis, root canal, implant placement, and implant crown. This is your treatment plan. Areas reviewed with cavitat, exam, 3D images. I've been advised they can get a second opinion. And by initialing below, you will have a driver available for after surgery. You always, if you're doing surgery or a really long, complicated case and you think that patient is not going to do well, maybe after some sort of anesthesia, you want to make sure that they agree that they have a driver. And I'm not talking about Uber. Okay? And then we have groups. We explain how this is. This is a computer group. This is one that was planned. This is the codes, avascular necrosis, biopsy. We were doing DNA biopsies with quadrant, and then primary closure of the sinus if that occurs, therapeutic drugs and other drugs or medications. We've been doing pulling of the blood, plasma-rich fibrogen on almost all our surgeries, and we put that back in. We'll use Tramiel. Sometimes I can even get a hold of the Sonum products I used to use because of the problem they had with the FDA. Group 2 refers to the, tooth number 4, so you have the tooth there, and then everything else, CPT code. I'm Dr. 1, T is the tooth, description is CPT, patient total charges, etc. And then down here we have them sign and date. We also have refusal of recommended treatment. How many people do this? I recommend you get a crown. Patient says, I don't want to spend the money. Okay. What do? You ask them to sign this. Refusal of recommended treatment. I'm not criticizing you. I'm not telling you that you're wrong. If you don't want to do it, that's absolutely fine. Oh, I know, I'm going to run late, Dawn. Dawn's giving me signs. 10 minutes or 15? Thank you. I have trouble. I got a 4-year-old, and when he does this, it's something else. An old fire like me has a 4-year-old, but we adopted our grandson. So possible benefits. Whoops, go back. What happened? All right. So it tells potential risks. I've chosen to refuse treatment after considering both recommended and alternative forms of diagnosis and or treatment of my condition. Each of these alternative forms of diagnosis or treatment has its own potential benefits and risks. So they just sign it, and then I sign it or my assistant signs it. So when that person comes back 3 years later and the tooth is broken and I pull out, oh, remember that? Oh, they don't have an argument. Then we have possible complications. Trismus, infection, bleeding, drug interaction, TMJ, local anesthetic problems, dry socket, damage to other fillings, sharp ridges, incomplete removal or tooth fragments. How many people do implants? Okay. How many people extract a tooth and immediately put an implant in? I'll do that. If you do, that's okay. How many people, once you prepare the site, take an x-ray before you put the implant in when you're doing an extraction? You've done the extraction. You've prepped the site. Do you take an x-ray before you put the implant in? You should. And let me tell you why. Her name is Lois. She's from Florida. She has scars here, here, and here from drainage pipes done by a periodontist. Pulled out 30. Thought he had all of them. Put the implant in. She comes back complaining of pain. He did another implant. It was fine. 2 weeks later, she comes back. Now she's off all anesthetic. She's swollen. Oh, you got an infection. This is rare. Leaves the implant in. Did take an x-ray. Doesn't show anything. Got so bad, she was hospitalized. They took the implant out, took an x-ray, and found 2 split roots. Yeah. She almost died. So if you're going to put the implant in immediately, which I'm not against, take an x-ray, make sure you got everything out, even if you've counted all the roots. Because I, who do surgery, am human. And I did an exam on somebody, and I looked at her, and we had done her surgery, and there was a root tip. And I looked at her. I apologized profusely. She came back 4 days later. We took it out, obviously at no charge, other than my pride. And then we took it out. Everything was clean. It worked out fine. Patient loves us. We talk about numbness. Today, a numb tongue in Arizona goes for about $350,000 compensation to a patient, regardless that they sign this piece of paper. That's why we're adding that little consent form that they'll go to arbitration instead of going to court. Upper lower teeth, sinus involvement. We have sinus involvement all the time. Has anybody used Steiner socket graft paste? I know you have, Alex. Larry, you have. You've done it. If you haven't, come talk to me about it. I don't get any kickbacks from Greg or his wife, Rosalind. But this stuff is the easiest and most wonderful stuff I've used when it comes to a paste for growing bone. It's a bisphosphonate. No, it's not bisphosphonate. It's a beta-tricalcium phosphate paste that, see, I got a sense of humor, that actually grows your own bone. Pardon? I couldn't hear you. Okay, vitamin K2 inside. The reason I want to make sure that the comments from the audience are made, that I can repeat it so it gets on the film. Okay, so consultation forms, you initial all these things. I consent to administer local anesthetic. I consent to have bone regeneration. I consent to use a membrane. I understand perfect results are not guaranteed. We're going to put those all in bold. And then I've read and discussed. Okay, so what do you do when complications occur? Nobody ever talks about this. If the patient has a complication, I want them to call me. Right there, the yellow part is my cell phone number. If you remember, on the very first part, my cell phone number is on the front. You can have your emergency number if you're more comfortable. Even a mandibular block can cause damage. Have an action plan. So notes, documentation, any extra notes, including phone conversations, referral to clinics. Keep records of healing progress. Majority of the time, situations self-resolve. Always refer these patients out if no improvement within 3 weeks. Give patient their option. Watch for 3 to 6 weeks. Refer to evaluate treatment. Pain specialist, oral surgeon. Have the patient sign your chart and give them a referral card. Give your copies, mapping to the other office. What's that about? I'll tell you in a second. Good communication between your patient can prevent a board complaint. Have your notes from referring doctors. Have a weekly progress. Charting in a new picture showing progress. Do not hesitate referring if you have a numb tongue. Know who the oral surgeon is. That's a big one. Because there's an oral surgeon in town known for doing these little microsurgeries to reconnect the nerve. And his comment is, well, you know, if you file a complaint with the board or sue your dentist, they'll get the insurance and the insurance will pay for my surgery. That's real professional. We found one guy who's the top guy in the valley. There's other guys out there. I'm not too much in steroid prescriptions, but if you take out third molars, sometimes if you do a Midol pack, it will help you. You can use lasers to treat, off-label though, and BioLase has a protocol with one of their lasers on that. And if a patient reports a numb of their tongue or area of their face, or if they have a pain after a dental procedure such as injections, restoration surgery, and any care, document it. And then use this. This came from Head and Neck. You have a record of the face. Everything's nice. It's laid out there. So what do? You go like this. Here's Mary Jo. On this date, she had numbness after surgery, the face and side. Over here, there, along there, and here. Okay? So what happens? You follow that. If you take a look, this is an actual patient. And the name's not right, but this happened. We had done surgery on some missing areas here, took out a root canal, and she's numb here to there to there. So May 15th, June 15th, bingo. We just got a little fuzziness there. Still can feel, but it's just a little numb, not too bad. When you show that to a patient, boy, do they get relieved. So, if you need sources of consent forms, this is an insurance company I found. Now, consent for amalgam replacement procedures and all this other stuff. I don't agree with everything they say, neither will you, but you'll have the opportunity to change it. And then, remember, the job is not finished until the paperwork is done. Okay? All right. We actually did that a lot less time than I thought. Any questions? If you need to contact me, this is my office, Thinking Outside the Mouth. If you want to contact me directly, just instead of www, put doc@mydentistaz.com. Yes. Well, basically, when I do ozone injections, I write down the condition of why I'm doing it. This is the biggest problem with people doing ozone, you know, and I've been guilty of this in the past. If you're doing ozone, write down the reason you're doing it, what area you're doing, how much, you know, do you inject, do you give them a local anesthetic? I know the first time I had it done to me, I was at a training course, and the guys who were doing it says, oh, let's do your shoulder, because I got a bad shoulder. I passed out from the pain after they told everybody it was nice and fine. And you guys know these guys too. So then I thought afterwards, gee, I'll just give myself a little ozone shot in the mouth. Well, after waking up from passing out and finding the needle on, true story, on the floor, I kind of figured maybe it wouldn't be a bad idea to add a little anesthetic. I've had requests to do tonsils, and I am amazed at the reaction of the tonsils after ozone has been injected, because these throats are just swollen so huge. Now that you can't use anesthetic on, and it can burn, but all the other parts you can. But what I usually do is anywhere from 3 cc's to 6 cc's, and at a 32 concentration or a 30 concentration for tonsils. And you see those things resolve so quickly, it is amazing to me. But I got a referral letter from the doctor saying tonsils are swollen, could you please inject with ozone? And I usually charge anywhere from $50 to $100 for the visit. Now, what did I use? $2 worth of equipment time, etc.? It costs more for the room to be set up and taken down and cleaned. But make sure your documentation is there. Get it if you're doing tonsils. Now, if you're doing the rest of the mouth, inserting ozone due to, is there an abscess? Is there pain in the area? How many people do trigger point injections for diagnostic purposes? Alex? Martha? Compendium, 1992, I believe, volume 10. Robert McMahon, oral surgeon, University of Indiana, did a 2-part article on trigger point injections. Janet Travell and David Kennedy wrote, not our David Kennedy, wrote a book, Trigger Point Injections, for diagnostic purposes. A lady came in 3 weeks ago, couldn't walk without limping with her right foot. She was in so much pain. Root canal, number 2. Did diagnostic injections up there. As I was capping the syringe, and diagnostic injections, by the way, and I have that, I'll probably be showing Sunday morning how to do that. 2 drops at the most in each location. You take the needle in the mucobuccal fold, you drag it, and you look for a bleeder. You're not stabbing it, you're dragging it. And you find a bleeder, and you put the needle in a millimeter, 2 drops. Go 2 millimeters forward, 2 millimeters forward, then behind it 2 millimeters, 2 millimeters, and watch to see if anything changes with the patient. This woman who was limping looked at me, started moving her right foot, got out of the chair, and started dancing. She did an Irish jig. Documented. Okay, Dawn is here. I have finished on time. This is a record. And I'd like to introduce our executive director, Dawn Ewing, savior of the world, my travel partner to the Philippines, where we had the pleasure this year of lecturing to the Filipino public. And Dawn, come say hi, and I want you to introduce Joan.
Okay. Hi, guys. Hopefully this is going to be an amazing weekend for you, and you're going to learn everything about biological dentistry you ever wanted to know, cared to know, or didn't want to know. It doesn't matter. We're going to make sure we cover all the bases. And for those of you that are hygienists, I'm going to take you away into another room later this morning, and we're going to learn everything you ever did or didn't want to know. As far as our next speaker, first I want to thank Mike. Mike, this is for you, but not really. It's for Lori, because I couldn't think of anything to get you. But Mike has put a lot of work into this particular weekend for you, so tell him thank you. He already lied to you once. The jump drives that you have in your possession, if you have a jump drive, are because when you signed up for the meeting, you said you wanted a jump drive instead of a paper syllabus of the meeting. Everybody who attended the Biological 101, whether it's hygiene or dentistry, you got a paper syllabus of this. There's no slides on the jump drive. There's no slides on the jump drive. If you
no slides on the jump drive?
Not of this particular, not of this. So he lied to you, but we
can make it happen.
Yes, we'll always backtrack and make sure that we get you anything you need. Okay, our next speaker is Joan, and she's going to speak on fluoride. Joan is our outgoing president.
Yay for Joan. Clap, clap.
Joan practices in Austin, Texas. Texas being the operative word, that's where we're from. So if you can't tell by my accent, and certainly by Joan's as well. And Joan has been really involved with getting fluoride out of everything. I mean, yesterday we took a tour, for those of you that are interested, to the Jack Daniel's distillery. Gosh, if you've never gone, you should go. It's a great tour.
Do they have fluoride?
No, there's no fluoride in the water. They use cave water. I mean, we were asking all kinds of bizarre questions. You know, it's GMO-free and preservative-free, and we even thought about buying little tiny bottles and throwing them in your grab bags. I don't know what the hotel would think about that. But anyway, I'm going to turn this over to Joan. You got it?